from the California Institute for Behavioral Health Solutions, formerly California Institute for Mental Health. This is the October Small County Fiscal TA webinar with Mike Geis. And just a few things as usual. All of you are currently muted, but Mike will be stopping for questions throughout his presentation. If you have a question, go ahead and type it into the question box, or you can click the hand icon next to your name and we can unmute you and you can ask the question in person. We sent out the materials this morning, but if you didn't get them, please send me an email and I can get them to you. And the last thing is that this is being recorded, so if there are other people in your agency or who want to see this and aren't able to today, or if you would like to see it again, we'll be sending out the link to the recording within the next couple of days. So other than that, I think we're ready to go. Go ahead, Mike.
Great. Thank you, Shoshana. Good afternoon. Today we're going to talk about what was discussed at last Thursday's Joint Information Technology Financial Services Committee meeting. And you can see the typical topics that we covered as part of that meeting. And so jumping right in with the short-doyle modernization update, this is the short-doyle modernization project, or what we've been talking about. Used to be, we talked about it as a feasibility study, but we're now getting a little bit further along on this. And actually, it's not CMHDA, CalMesa, and DHCS, but CBHDA, CalMesa, and DHCS drafted a proposed charter, which hopefully you had a chance to take a quick look at, and this was included with the handouts today. So this is now official, and we're basically waiting for the governance committee to, who are all listed there, to go ahead and sign off and approve the charter. And what I want to focus on with the charter, really just this in-scope area here. And so it's because it is different than what it was initially, and I think we've kept you up to date with what's going on. And so there's really three parts to this. One is this federal reimbursement pilot study, which is probably the what you'd be mostly interested in. And this is looking at changing from our existing system, our existing cost-based retrospective reimbursement systems, adjudicated claims system, to more of a prospective payment system, either case rates, capitation, or whatever whatever is ultimately identified as the best approach. And so this pilot study would look at the kind of the per member per month type of costs, risk adjusted, meaning looking at different aid codes, age, sex, other demographics, to see what sort of commonalities and so forth that we could find in developing almost a per member per month sort of payment system. The pilot would be to identify these variables and test them and see how they look across counties as well as within the county. We then want to, and really looking at probably 3 to 6 counties to participate in the pilot, that would really allow us, I think we have some ideas going in of what it might look like, but we definitely would want to test it with the 3 to 6 counties. And based on that, come back and draft a white paper outlining the methodology. Ultimately, that would probably go then on to CMS. And then to the extent that we needed to, we'd either implement a state plan amendment, and I say and or waiver changes. It actually could even be a completely different waiver away from our current 1915B waiver. but all that would be decided as we go through this process around the federal reimbursement pilot study. The other thing I think at this point, and we talked a little bit about this in the meeting, is that the scope is really just on mental health and not does not include the drug Medi-Cal program. But that doesn't mean that down the line drug Medi-Cal wouldn't also be incorporated into this, to where we had a behavioral health reimbursement system. So that was the first aspect, was this federal reimbursement pilot study. The second aspect are the Short Doyle 2 enhancement project, and the IT committee's SWAT team has, and actually Cal Mesa sent out a survey where you identified, and you can see the top two things there: improve reconciliation process and fix current outstanding stuff. And really looking at prioritizing the system changes through the SWAT team. Ultimately, since Cal Mesa is the one shepherding the process, they would have to approve, their board would have to approve the changes. And this is really where you folks are contributing the funding for this. You'll remember it was a while ago you were asked to become part of the project through Cal Mesa. And I'm not sure, there wasn't a discussion from Cal Mesa on this project at the meeting, but I believe quite a few counties have agreed to contribute funding. And so now that this project charter, once it's finalized, and it's something that you can take to your board of supervisors more concretely and say this is what the funding is going towards, as well as the actual improvements to the Short Doyle system, then hopefully there will be some funding provided by counties to go ahead and implement these system changes. And then the last thing is this long-range MIDA planning. And again, we've talked about this before, where part of the MIDA maturity is having to deal with not having a siloed mental health system, and to incorporate it into, with the other data systems. And so, again, having a data system, mental health data system, that is capable of exchanging data with the other health data systems, looking at encounter data versus claims-based data. And so, again, differentiating data being submitted to look at outcomes and performance from how you get paid, which would be different than where we are now. And so, again, where this goes is, I believe it's going to the governance committee for approval. And once they hopefully say it looks good, then we'll move on, and we'll go ahead and ask for county volunteers. We'll definitely have some small county participation, hopefully, in the pilot study, so that we can continue to move forward. I think ideally, in a perfect world, we'd be looking at a new reimbursement system beginning in fiscal year 16-17. I'm not sure if we can get there that fast, but that would, I believe, be the ideal system. So, any questions on the Short Doyle modernization update?
There's just a question about whether you already have any counties identified for the pilot.
Not at this point. Not for this project. So there have not been any counties identified. I would imagine we're probably going to have to more so ask for volunteers, because I think it may take a little bit of resources from the county to actually participate. And so rather than saying we'd like these counties to participate, it's going to probably be a volunteer thing. But we don't have anybody selected yet. And again, really the next step is to get this this charter through the governance committee, so that everybody's on board with where we're going. All right. right, moving on to the shortgo 2 update. And again, since this was a joint IT Financial Services Committee meeting, we had a much more detailed report on some of the shortgo 2 issues from Dan Walters of the SWAT team. So a lot of this are issues that the SWAT team has been dealing with and continues to work on. So starting off with the netting and void process, my understanding is that the SWAT team and you counties are basically waiting to see some of the 835 files with these transactions in them to see if the process actually works. And so until that happens, we don't know if the process will actually work. And we talked a little bit about, well, we just received an update on the CPT code crosswalk that the SWAT team developed and submitted to DHCS for review and comment, and that is still sitting at DHCS, and we have not heard anything back on that. We talked a little bit about the adjudication of claims with multiple aid codes, and so these are proposed system changes to the short oil system to select the highest paying aid code for clients that have multiple aid codes. And there is, I guess, a proposed, or it is in the queue to make changes to the system, but currently the short oil system does not adjudicate at the highest paying aid code. So obviously we have concern about this with respect to cost settlement and audit, probably more so audit than necessarily cost settlement, because cost settlement, you're more looking at your own records versus the state's records. But at audit, when the auditors come out, they may have inaccurate or incomplete data when they audit you. And the other part of this is that a lot of these, well, not a lot, but some of these claims may be pretty old, maybe up to 4.5 years old. So definitely keep an eye out on that. And then, you know, the state's willing to work with each county to identify the scope of the issue, and they've assigned this specific ticket number if you're emailing or contacting MedCCC. And apparently some of the counties have already submitted data, and I guess the state is just starting to take a look at that. So more to come on these multiple aid codes. And then we talked a little bit about the Medicare Advantage Plan claiming, and really it sounded like that you folks need documentation as to what the required 837 segments and loops are for the Medicare Advantage Plan claiming. And what I heard was that you're really looking for a companion guide on how to do some of the billing for folks who are in Medicare Advantage plans, so that you can make sure you're complying with what the state wants, and so that the services don't get denied. So any questions on any of that? All right, moving on to more short oil 2. Talked a little bit about the ICD-9 and DSM-5 implementations, and so ICD-10 is, I believe, required to be implemented October 1st, 2015. It can't be implemented or used before that point in time. And the counties, again, have asked DHCS to identify what they're proposing to change across all the state data systems. So not just the short oil system, but the you know, CalOMS, DCR, any of the state data systems, so that you can go ahead and make changes to your system to be ready on October 1st, 2015. The vendors, I guess, have indicated they require at least 9 months lead time to make the changes to the systems. And if you think about that, you know, that's really that's less than 3 months away from where we are now. So hopefully within the next 2 to 3 months, the state will identify all the system changes so that you can alert your vendors as to what needs to be done prior to October 1st, 2015. State DHCS indicated that they've developed a project team to deal with the implementation of ICD 9 or 10. They apparently have not made a decision on what they're going to do with DSM-5, if they're going to do anything prior to the ICD-10 implementation. But they've developed and identified a project team, and they're developing a project charter and developing information notice to keep you informed as to what's going on with that. And obviously, the counties through the SWAT team are willing to assist the state in any sort of changes or testing or anything like that related to the system changes associated with moving to ICD-10. So any questions on any of that stuff?
There is a question, hold on. Regarding adjudications of claims, multiple aid codes, Butte received a blank spreadsheet and was asked to fill it in. I thought DHCS was going to provide some of the data.
So that's interesting. You know, I don't know. So they said they wanted to, and they didn't talk about it at this meeting, but I think it was last meeting where they said they're willing to accept whatever information the counties have and then compare it against theirs. So it sounds like they are basically at this point asking you for your data to compare against theirs. We brought up, again, not this meeting, but 2 meetings ago, that obviously this is a small county resource issue for you folks to have to try to dive into this, and many of you just don't have the resources or potentially even the claims expertise to dive in and look at how many and which of your claims are have the multiple aid code. So at this point, I wouldn't, to the extent you can fill it out, that's great. But if you can't, then I would suggest probably just referring back to MedCCC, saying you don't have the issues or the resources to work on this, or you want some technical assistance, or you want them to identify the data that they have that has multiple claims and see what happens. I think definitely we're going to have to talk about this at the next Financial Services Committee. And more than likely, this is being discussed on the weekly SWAT calls on Thursday afternoons. But anyway, that's all my guesswork on that. All right, moving on to the claims payment update. And so Cal Mesa has been trying to champion some reform issues around the state hospital payments for you folks. And they were on the phone and identified 4 open issues with respect to the 1415 MOU with the Department of State Hospital regarding state hospital beds. And the one really good thing is it sounds like that the state is going to move towards actual usage of state hospital beds in terms of charging you versus you having to buy a dedicated bed irrespective of whether you used it or not. So, and I guess the way they're going to get around some of the statute or regulatory language is to say that you can designate 0 guaranteed beds, but then they're just going to bill you based on the actual beds that you use. This apparently became effective last month in terms of last month, the actual bed usage from last month, and so that's what your bill or your offset that you're going to see for October. It sounded like the rest of these things were still in negotiations. That included the daily rates, and it sounded like they were looking at a blended rate of $626 a day. They're still in negotiations over the third-party reimbursements and I guess how those should be treated with respect to the billing. And then the last thing was that the statute allows you, rather than having an offset to your 1991 realignment for state hospital costs, that you can actually pay it directly to the state, and so they wouldn't do an offset on your 1991 realignment. The problem is the state doesn't have a process in place to allow you to do that, so it sounds like that is still being worked out, that that would allow you to actually cut a check back to the state rather than having an offset to your 1991 realignment for state hospital beds. And then we talked a little bit about cost report settlements, the 910. It sounds like there's 10 counties that are still working on the reconciliation process. 1011, there were also some counties still working on the reconciliation process. But really one of the things that came up that I don't know if we had heard before was that the state doesn't have the appropriation authority if they owe a county funds to settle either 910 or 1011. And unfortunately, so they're working with the Department of Finance on how to do those settlements, but more than likely it requires legislative action, and that basically means it won't happen until next calendar year in terms of actually getting cash if they owe you money for either 910 or 1011 cost report settlement. Then we talked real briefly about electronic funds transfer, and that basically nothing new there, that it's still in testing. And then one thing I forgot to put on here was they did mention that the 1314 cost report template for Medi-Cal Specialty Mental Health Services does have some errors, and that they were going to try to have a new template out. I thought today, but I looked earlier today and I didn't see anything out there. And so this is for the 1314 detailed template on the Specialty Mental Health cost report. So hopefully that will be out soon, since we're sitting here in October, so that you can get those cost reports done. And then we also didn't hear anything about when the 1314 summary cost report template would be available. Does anybody have any questions on any of those issues? All right, moving on to drug Medi-Cal update. So the fiscal year 14-15 contracts are supposed to be sent out by the end of this week. I think I said the exact same thing last month, and they didn't get out, obviously. And this is the NNA contract that includes both drug Medi-Cal and non-drug Medi-Cal. And apparently part of the holdup is because the Department of Finance is taking a look at some of the requirements that that may be new for counties, and so they have an interest in making sure that the contract terms are appropriate and don't create additional burdens on counties. The drug Medi-Cal provisions are supposed to be modeled after what you see on the Medi-Cal Specialty Mental Health contract, so hopefully those are very similar for the drug Medi-Cal program. However, the overall contract, I guess, is very different than in prior years, so you want to make sure and take a look at that pretty closely. And the one thing that is incorporated into that are your ability to claim for administrative costs through the quarterly administrative claiming process, as well as it will probably spell out your responsibility for utilization review that you didn't have before. And so you definitely want to take a look at some of those provisions, and hopefully, like I said, it comes out soon here, because they are not paying any of the 14-15 claims until they have a signed contract back. So it really hasn't been an issue probably yet, but it will start to become an issue from a cash flow perspective if you don't have the ability to sign the contract and get it back and actually then start to get paid for some of the services that you're providing. We talked quite a bit about this whole physician diagnostic requirement, and apparently DHCS is working on a set of frequently asked questions. But really, well, so a couple things. They're also looking at the DSM versus the ICD-9. Apparently there's some costs associated with using the DSM, and so you'd have to pay a subscription fee to the American Psychiatric Association. So hopefully that won't be a requirement, and they'll just wait for the ICD-10 like we talked about before. But the physician diagnostic requirements, and it actually kind of gets into the next bullet, where the state plan amendment was approved by CMS, and it requires that services are prescribed by a licensed physician. And so there's definite concern that the prescribed means a face-to-face visit with a licensed physician. This is different than what the state included in their emergency regulations, but the reality is what's in regulations from CMS's perspective doesn't really matter, and it's more what's in the state plan. And so the state plan will dictate your drug Medi-Cal requirements, and even if the reg is a lower level of requirement, you're still going to have to do whatever's in the state plan. So definitely more to come on this. It sounded like even though it does say prescribed, it's not real sure if that means face-to-face. It also sounded like that the folks who worked on the SPA did not insert the prescribed language, and that it came from somewhere else in the department, and so they're researching where that came from. But in any case, there's definitely more to come on this one. And so again, clearly, the state issuing an information notice or frequently asked questions to the extent that they are not consistent with the state plan, they don't really help you. And so when the auditor comes out, they're going to audit to the state plan requirements. And then finally, we talked a little bit, although not much, about the 1314 drug Medi-Cal, or the substance use disorder cost report. That has, I guess, not been released yet. And DHCS is looking at delaying the submission date beyond November 1st, but they did not provide a date as to when they would expect the due date to be. And all it really does is, unfortunately, just kind of keeps backing you up, because you've got the mental health cost report to do, and by the end of the year. And so even if this one's delayed, it doesn't really help you out too much, because you've got other cost reports that are due. So any questions on any of that stuff? All right, moving on to the MHSA update. And this kind of feeds into that same line as the drug Medi-Cal cost report, in that the 1213 MHSA revenue and expenditure report is supposed to be released the end of this month, probably through an information notice. I know the Oversight and Accountability Commission is going to provide some input into that format. The good news is it sounds like the due date will be January 30th, 2015, which is a Friday. So you would have, at least the month of January to look at doing the MHSA revenue and expenditure report. We didn't talk about at all what the 1314 report may be or when it would be released, because really they're basically a year behind in terms of releasing the format and the due dates in terms of what the statute says. So I wouldn't be surprised if, well, I have no idea. I have no idea when they're going to come out with the 1314, but hopefully at some point they start to catch up, because it'd be nice to do the cost report and then do the revenue and expenditure report for the same fiscal year rather than lagging by a fiscal year. And we talked a little bit about the 14-15 MHSA distributions. The state did issue information notice 14-029 that basically says the same percentages. Well, it doesn't basically say, it does say the same percentages as last year. So there were no changes to the distribution percentages for 14-15. I think they do have some estimated revenue figures in there that you can apply against those percentages to get an estimate of what your 14-15 distributions will be. But then they did go into mentioning that for 15-16 they are looking at potentially changing the distribution percentages. And one thing they're trying to take into account is the Affordable Care Act and what sort of impact that may have on the distributions. You know, I would hope that they would involve the Behavioral Health Directors Association as well as other stakeholders before making changes in 15-16, because more than likely 15-16 distributions are going to be less than 14-15, and so to try to make changes to the distribution approach in a year in which revenues are lower obviously would have potentially some pretty big detrimental impacts on counties, which may be hard to deal with a decrease in revenues anyway. So hopefully they may reconsider whether they're going to look at it for 15-16, but they did mention they are, and we'll see where that goes. Anybody have any questions on MHSA? All right, moving right along. The state and federal budget update. So again, there wasn't much really discussed here. They are working on the claiming forms and definitions for your KDA administrative claiming. I know at the last meeting they had said they were going to try to have those out this month in October, so that you could submit the first quarterly claim, which is July through the end of September, and you would actually be able to include costs associated with KDA administration. So, and they also said, you know, initially it looks like it's primarily dealing with preparation of the quarterly progress reports, but again, it's how is that defined, and so we're just waiting for more information so that you can identify hopefully those costs and claim those to the state along with your regular administrative claim, and the one difference being that this would be 100% reimbursed. It would be state general fund and the Medi-Cal FFP versus your other administrative costs that are only 50% reimbursed with FFP. So hopefully we'll see that out pretty soon. We didn't really talk too much about the 14-15 behavioral health subaccount allocation percentages. I'm not sure if anybody there from the state really had very much detailed knowledge of them. But just in looking at them, it sounds like they are the same percentages as what we had in 13-14, except that there's now a $100,000 minimum drug Medi-Cal allocation to every county. So it basically reshuffled about $1.7 million. And so I think some of you would see that your percentage went up from 13-14. If you look at your percentage of the distribution that just went out the end of last month, it's going to be a little bit higher, and that would be because of this $100,000 minimum drug Medi-Cal allocation. But again, we don't have any support for that. They haven't issued an information notice, and so it's just what they said in the meeting. The one thing is that even though, and then just again in spot checking it, it looked like some of the larger counties' percentage went down slightly because of some of the small counties' percentages going up. But I still think, given the growth that we saw in 13-14, nobody's percentage was modified that much that they wouldn't receive more money in 14-15 than they did in 13-14. So even though some of the large counties' percentages may have gone down, the growth should more than cover the growth that occurred in 13-14 that will increase the 14-15 base, which is about 40 to 60 million. That should more than cover, so that everybody should see an increase in their actual behavioral health subaccount allocation in the current fiscal year. But we won't know the actual numbers until they calculate that, which usually is sometime this month, once they do the full reconciliation for the 2011 Local Revenue Fund. Anybody have any questions on any of that stuff?
There's an MHSA question. When they create the new distribution formula, will you let each county know what that means to them? How will the change be communicated?
So I would imagine that as the state goes through the process, I don't think the state's just going to up and change the formula without consulting the counties, contract providers, other state, the OAC, and other stakeholders. So I don't think it's all of a sudden just going to happen. They started the process, maybe 6 or 8 months ago for what they said they were going to look at 14-15, but then they kind of backed out of it. I think they just ran out of time and resources to really take a look at it. So I would imagine that we'll be very informed every step of the way. Ultimately, it would be communicated through an information notice. But again, I think the CBHDA position has always been that in years where there's a decline in revenue, that everybody realize the same percent decline rather than reshuffling up this thing. The other thing that I don't know if the state folks quite understand, or although I think the Department of Finance folks are starting to get more and more on the behavioral health subaccount, but I'm not sure if you've got different people working on the MHSA allocation. They don't understand that you've created programs with that funding, and for all of a sudden the whole thing to be shuffled doesn't make sense, because you could actually even have a year in which revenues increase and a county receives less funding, which would require potentially dismantling programs. So this whole concept of base allocations and then any changes being affected through growth is critical, and it's one that CBHDA has always pushed for on your guys' behalf, so that you can have some stability in some sort of base allocations. But the bottom line is that for 15-16, I would think this will be an agenda item that we'll talk about every month for probably the next 9 months. So pay attention to the Financial Services Committee as well as listen into these calls, and we'll keep you up to date with what's going on. All right, moving on to the work group updates. And again, I'm not sure how informed the state representative was who was there, so we didn't get that detailed of an update. But it sounded like, again, so on the fiscal state plan amendment, one of the critical issues is being able to claim for actual costs above SMA back to January 1st, 2009. And one of the issues that we were hoping to have addressed as well was this concept of applying the lower of cost or charges to government providers, and we don't believe that it should be. And DHCS agrees, DHCS Legal Services agrees. CMS may need a little bit of convincing, so it sounded like the state was going to submit the state plan amendment, and I'm not sure if formally is the right word, but I think they're definitely submitting what's called the RAI, or the Request for Additional Information. And I don't know if that starts the clock for CMS then on the 90 days that they have to either approve or deny the state plan amendment. I'm hoping it does, because we kind of need some resolution on this. And as I've talked before, if CMS does not agree with the lower cost of charges, I think we do have some agreement with some of the folks at DHCS that the criteria that they apply through the cost report is more detailed than what it really needs to be, and is more detailed than what's in the provider reimbursement manual, CMS's provider reimbursement manual. So even if we don't get that part through the state plan amendment, there may be other ways to which you can qualify as a nominal fee provider without having to go through all the rigmarole that is prescribed in the cost report. So hopefully, they'll submit that by the end of this month, and we'll hear within 90 days what's going on. And then at that point, so that puts us, the end of January, and hopefully the state's pretty much ready to go with the supplemental claim form, so that for those of you who were reimbursed less than your actual costs, you can go ahead and submit the supplemental claim form for any of the fiscal years that you've either been audited or settled, and get the additional FFP. But we'll definitely hear more, I think, at the next meeting, and with respect to that. All right, then the last thing, we had some county-to-county issues that we discussed. The audit and appeals was an issue brought up by Los Angeles, where they're, in their audit, they have been told that they can't appeal anything on behalf of a contractor. In other words, the contractor's units of service, which is something new, that you've always had the ability to appeal on behalf of your contractors for the units of service, because the relationship is between you and the state, you as the mental health plan. So not sure where that was coming from, and it sounded like nobody else had experienced that issue. So it could just be kind of a new auditor in LA or something else. But anyway, no, it didn't sound like anybody else had that issue. We then talked about whether you should be billing other counties for epsdt, and this is where you're providing services to another county's beneficiary, and it's an inconsistent practice. Some counties do bill, some counties don't. I was surprised to hear that there are counties that are billing the 50% match for epsdt, since you are getting some reimbursement through the behavioral health subaccount for epsdt services. In any case, there was a motion that was made to take to governing board that counties discontinue billing each other for epsdt, and so we'll see where that goes, or if it goes anywhere. Then we talked a little bit, and we had already talked about the CPT crosswalk, but really there was, again, some concern expressed because there is no state DHCS approved or recommended CPT crosswalk, that you guys are basically putting yourself at risk because everybody's kind of doing it potentially differently. So hopefully that will get reviewed and resolved soon, so that so we at least have some protections. I actually thought it was in regulation that requires the state to do that, to publish a CPT crosswalk for, and these are for the fee-for-service Medi-Cal services, your Program 2 services, with your panel providers or network providers, whatever you call them. And we talked a little bit about the 1112 AB 100 epsdt final allocations. And if you remember, Riverside had brought up that they didn't agree with the state's calculation of their epsdt claims. And so the state took a look at that, and actually the state did say that they made an error in looking at the claims. And this is so as part of the AB 100 distribution in 1112, it covered 1112 epsdt services, as well as it covered fiscal year 8-9 cost settlement where the state owed the county money. So if you were owed money, you were paid through the AB 100 allocations. Well, because the state made this error, and basically they included inpatient claims for 12 counties with hospitals when they calculated the ratio to apply against epsdt claims, it results in 7 counties being owed $4.1 million for 8-9 epsdt cost settlement, over and above what had previously been paid, obviously all large counties. What that theoretically or technically means is that there is less AB 100 funding for 1112 epsdt services had that $4.1 million been included in the initial calculations, which means that everybody was overpaid for 1112 epsdt services. And so what we talked about was potentially seeing if the state can pursue a state general fund solution to this, because it's their mistake. And so, again, technically, if all the money would have been put out, they would have had to try to go back and collect from every county. And so I think at this point we're going to recommend that they see if they can't deal with it through a state general fund sort of approach, which then brings up a whole nother issue, and that is, how is the state looking at the fiscal year 08-09 audits with respect to epsdt payments? Because technically AB 100 funding for counties who were owed money as part of the settlement process, AB 100 funding was used to pay for part of your 8-9 epsdt services. So if the state then comes in and recoups money through the audit process, they're technically recouping AB 100 funding, which I don't believe they have the authority to do. So we're going to be, we being CBHDA, will be talking with the state about this, but it's something as you go through your 8-9 audits to definitely be aware of. I doubt very much that any of the auditors would have any clue that there was additional payments made with AB 100 funding, rather than it all just being state general fund monies. So your auditors probably aren't going to have any clue, but definitely something to pay attention to, and hopefully we'll have some sort of guidance pretty quick on what the state's going to do or not do, and then we may have to deal with this through appeals, which would be a different kind of appeal, because it would question the authority of the state to actually recoup these funds. So more to come on that. And again, we talked a little bit more in county to county about the shortgo modernization project, saying that there is this matrix of things that need to be done to keep the short oil system operational. Basically, those things that need to be done, somebody needs to figure out how much that's going to cost, and so that you can get an idea, given the amount of funding that will be provided by counties, how much actually can be done. Some of the changes, I guess, may require legislative changes, and some may require policy changes in terms of how the state currently handles claims. And then we talked a little bit about this kind of the long-term solution, which is the MIDA, and having a behavioral health system that's integrated into the overall healthcare system. And apparently the state was actually looking at migrating away from short oil and putting our claims into the Xerox fee-for-service claims processing system, where really we would rather be in the encounter-based data system with the other health plans, so that again we're differentiating payment from data reporting. So we'll see where that goes, but hopefully the state won't put us into the Xerox fee-for-service system, because there really is no reason to do that if we go to a payment structure that moves away from claims-based adjudicated claims as your basis for payment. And then the last thing, just real quick, wanted to talk and put a plug in for the fiscal leadership training. And apparently there is a webinar October 17th at 8:30 a.m. And if you're interested in participating, they've already had one webinar, but if you're interested in participating in this webinar, contact Adrian at CIBHS, or you could probably contact Shoshana, who could forward it on to Adrian. And then the actual fiscal leadership training, or Fiscal Institute, is going to be December 2nd and 3rd. So Tuesday and Wednesday prior to the Financial Services Committee meeting on the 4th. And one thing that we're thinking or we're looking at doing as part of that Fiscal Leadership Institute is providing a special session for small counties. And so if you have any ideas, either around IT topics and or financial topics that you would like either Thad Dixon or myself to cover in a special small county training, if you could email those to Shoshana, and we'll take a look at that and see if we can't put something together specific just for small counties and have more of a face-to-face training just for you folks dealing with issues that are specific to you. And again, email Shoshana with any suggestions that you have on that. And then the one last thing, as we were talking, that I just remembered, was that our next call, the next Financial Services Committee meeting isn't until Thursday, November 13th. It's later because of the Governing Board's strategic planning meetings. And so our next call won't be till the middle of November, November 17th. So a little later next month after the Financial Services Committee meeting. So we've got a couple more minutes. Anybody have any questions or anything else you want to talk about, or like I said, any questions?
Quiet group today.
Yeah. Everybody's gearing up for cost reports, so. Okay, well then we'll go ahead and sign off a little early, and like I said, we'll have another call a little bit later in November. But in the meantime, probably pretty soon, if you think of anything you'd like to have some specific small county training on, please email Shoshana, and so we can put something together around the Fiscal Institute in December. All right. Thank you.
Thank you. Bye.
Bye-bye.
Everyone.